Good morning, dear colleagues. This video will present our technique for ACL and posterior medial corner reconstruction using an over-the-top technique, plus lateral plasty, and a minimal invasive double band reconstruction of the posterior medial corner without tibial tunnels. The patient is placed supine on the operating table. A tourniquet is applied to the upper thigh. Evaluation under anesthesia indicates a medial joint opening at both 30 degrees of knee flexion and in full extension. Medial collateral ligament anatomy is outlined. For this procedure, our graft choice is an autologous semitendinosus harvested from the patient's contralateral leg. Both free ends of the graft are prepared with a number 2 fiber wire using a baseball stitch configuration. Standard arthroscopic portals are established. Any associated injury is detected using a probe through the anteromedial portal. The drive-through sign confirms the pathological medial joint line opening. A medial meniscus lesion is detected and arthroscopic meniscal repair using a null-inside technique is performed. Attention is then shifted to the medial aspect of the knee. A 5 cm oblique incision is made over the pes anserinus and the posterior tibial region, allowing us to identify the pes anserinus and the MCL complex. The semitendinosus and gracilis tendons are harvested while preserving their tibial insertion. These are then configured into a double-stranded graft using 2 Ticro number 2 sutures. After identifying the tibial footprint of the anterior cruciate ligament with the elbow compass, the guide wire is fixed positioned and subsequently the tibial tunnel is rimmed. Afterward, any remnant tissue are removed from the footprint using the shaver. A transport wire is treated intra-articularly through the tibial tunnel and then retrieved with grasping forceps. Subsequently, we focus on the lateral aspect of the knee. A targeted incision is made over the iliotibial band, which is then incised. An over-the-top technique is performed using a clamp and a shuttle wire. The tendons attached to the tibia were passed through the tibial tunnel and in the over-the-top position. The knee is flexed to 90 degrees with 45 degrees of external tibial rotation and the posterior drawer is applied. The tendons were then fixed to the cortical bone of the femur with 2 bone staples under maximum manual tension. The remaining part of the graft is then passed deep to the iliotibial band, superficial to the lateral collateral ligament, and fixed with a single staple onto Gehry's tubercle as extra-articular plasty, with the knee flexed at 90 degrees with neutral tibial rotation. We check anterior laxity at the end of the first step of the procedure. Attention is then turned to fluoroscopic guidance for identifying the starting point of the femoral tunnel. A 3 cm half tunnel is created and the shuttle wire is passed through. The graft is looped around this wire and pulled into the femoral half tunnel. To anatomically replicate the superficial MCL, SMCL, and the posterior oblique ligament, POL, the graft ends are adjusted, longer anteriorly and shorter posteriorly. A bioabsorbable interference screw is used to ensure its fixation on the femur. Afterwards, a pull-out test is then performed to validate the strength of the fixation on the femur. A medial blunt dissection is performed with a clemmer along the native MCL fibers until we visualize the clemmer exiting from the femoral incision. The graft ends are navigated through the soft tissue planes and a 5.5 titanium anchor is placed about 2 cm below the tibial plateau, on the tibial anterior cortex. Subsequently, isometry of the SMCL graft is tested and then fixed using 2 titanium staples. SMCL additional tensioning is achieved using a 5.5 titanium anchor previously placed. Finally, the POL graft is fixed using titanium staples at the medial posterior corner of the tibia. Native POL is anisometric, so no isometry tests are required here. Thank you.